I'm here with Alan Eade to discuss some of the broader challenges and changes that occurred with the pre-hospital care during the course of the pandemic. Alan, thanks so much for taking the time to join us.
For having me. It's a pleasure to be here.
Alan, you work both as a practicing intensive care paramedic, a MICA paramedic with Ambulance Victoria, so you've attended to patients with COVID or suspected COVID, and you also work as the Chief Paramedic Officer. So you have some insight about some of the things that happen behind the scenes in terms of pre-hospital care. So we want to tap into both of those roles and experiences. And our first question is, what have been the most significant challenges specific to airway management over the course of the pandemic?
I think all clinicians, particularly out of hospital, the overwhelming fear and anxiety has been related to the infection risk. Am I going to get the infection? Personally, I thought I'd be okay if I got the infection, naively at the very beginning. But I was very worried about whether I would take the infection home and bring the risk home. So we did a lot of work very early on around going home safely. But associated with that, and specific to airway management, as you were saying, the Safe Airway Society guidelines that came out very, very early on in the pandemic were world leading, and implementing guideline adjustments for the out-of-hospital providers around aerosol generating procedures was one of the very early steps that was taken to try and prevent and reduce the impact of the infection risk on the providers themselves and them taking it home. I think that the other aspect that has really been present throughout the pandemic has been the perception of the adequacy of the care we're providing, or the safety of the care that we've been providing. And there's a lot of discussion now in the literature around moral injury, and I think this is going to be the thing that hangs around for a long period of time. This will be the long COVID tail for the workforce. We changed our access to healthcare. We changed the outcomes that we're seeing from our healthcare. There's published outcomes in cardiac arrest which show a halving of outcome. The indirect impacts of COVID on slowing our systems and our processes of care. The impact on not just the patient but their family, lack of visitors, inability to support people to health services, and the communication challenges that come with PPE. They can't see you cry, they can't see you smile, you're stuck behind a mask. It's been very, very difficult to show and display empathy. The last part is around communication in broader terms across the health sector. Multiple guideline changes, seemingly endless guideline changes at some points, ever-changing PPE guidance from an ever-increasing number of people that want to have an opinion, and then a focus on PPE to the exclusion of all other aspects of safety, so physical distancing and appropriate hand hygiene. We don't have negative pressure rooms in the pre-hospital space, but we do have wide open spaces. Using those really sensibly and logically and pragmatically is actually one of the keys to providing safe care.
Thanks, Alan, and no doubt those challenges have been quite consistent across Australia and perhaps the world. For our second question, we want to change tack slightly and ask you about some of the benefits that COVID-19 has brought with it. So in your experiences, once again, in your various roles, what have been some of the changes that have benefited patient care or the practitioner, and which of these are likely to remain into the future, even once the pandemic subsides?
There's been many things that are actually good that have come out of COVID. I think infection prevention and control is the overarching one that will remain. The paramedic profession has traditionally been rubbish at infection prevention control, but transmission-based precautions and effective hand hygiene, these are things which are just going to be now, thankfully, and well overdue, commonplace going into the future. I think that the concept of what is an aerosol generating behaviour on top of an aerosol generating procedure, and the fact that we need to take adequate precautions associated with those, that'll be the big thing which remains. That'll be the language which we take forward. It'll also be the change that we see. You will not see people in the out-of-hospital space intubating the patient with an unknown history without facial and eye protection into the future. It will look as weird as it does today for you seeing somebody try and cannulate without wearing gloves. And I think that's a real positive for us going forward.
Yeah, couldn't agree more. Alan, that's all we've got time for. Thank you so much again for taking the time to talking to us, and thank you for all the work you've done and continue to do in this space. It doesn't go unnoticed.
Thanks, Matt. I actually think that the credit goes to the clinicians that are out providing healthcare, no matter where it is, whichever environment, whether it's in hospital, out of hospital, the retrieval services, if you're in ambulance or transport, or in any other factor. The people who've been doing it hard are the clinicians. They deserve our respect because they've been amazing.